I'm going to introduce Dr. Danielle Andrade, who's the medical director of the epilepsy program at the University of Toronto and director of Krembil Neuroscience Adult Epilepsy Genetics Program. Dr. Andrade is an expert in the treatment and the study of Dravet syndrome in adult patients, and that's the topic that she is going to be focusing on today. With that, I will let the recording of Dr. Andrade's talk begin. And just remember, she'll be joining us also for a live Q&A, so keep all of those questions coming.
Hello, I'm Dr. Danielle Andrade from University of Toronto in Toronto, Canada, and I'll be talking to you today about adults with Dravet syndrome. So here are my disclosures, and here's the outline. I'll talk to you about seizures in adults, treatment of newly diagnosed adults with Dravet, a little bit about day-to-day and motor disorders. So just recently, we completed a systematic review of papers talking about adults with Dravet. And when you do this kind of research, it's clear that there is way more research in children than in adults. When we look at all the papers that had been published about Dravet syndrome, those that were not just about the genetics or about animal models, and we just got the ones talking about patients and what happened to patients, we saw that for every 7 papers in children with Dravet, there was only 1 paper in adults with Dravet. So there is a significant lack of research and knowledge about what happens to adults with Dravet syndrome. So what I'm going to show you is in part some of the studies we did and our colleagues and collaborators, or some other studies done by other investigators about what exists out there in the literature about adults with Dravet syndrome. First thing is seizures. So the period of very active seizures will end at different ages in different patients, but most patients will start to have less severe seizures or less frequent seizures after the age of 13 years. The myoclonic seizures, those jerks, and the atypical absences, they tend to decrease in adults, and some adults will even stop having those types of seizures. Many adults will be less sensitive to fever, but they can still have fever-induced seizures. They can still have seizures when the environment is too hot or their core temperature increases because they took a hot bath or exercise in a hot day. So that can still happen, but it's less frequent than in children. Children definitely are more sensitive to hyperthermic-induced seizures. The other thing that happens in adults is that their convulsive seizures tend to happen more during sleep. So either as they are falling asleep or waking up. So in a way, it's a bit better because they are safe in bed. On the other hand, we are a bit more concerned because they might have seizures unsupervised. But the thing is, they tend to happen more during sleep, even if it is a nap during the day. Good news is that ICU admissions because of status epilepticus is way less common in adults than in children. However, adults might have some periods of increased seizure activity, and sometimes we look for a cause and there's no infection, there's nothing that really triggered that bout of seizures again, and it stays like that for a while and then eventually calms down. So it's not like seizures will simply go down and hopefully eventually disappear for some patients, but they can have these ups and downs, but they tend to go down with age. And some adults can become seizure-free, which is a great thing. We have a few adults in our program who are seizure-free. I have tried to reduce their medications. They started having more seizures when we tried to reduce, but this is just a small proportion, and there might be other adults that can become seizure-free with less medication. So that's something that we also need to look at from my research point of view to understand that better. In terms of how we treat seizures in adults, it's basically the same thing as you treat in children. So the challenge is when the patient receives the diagnosis when he's already an adult. And there are, as you might know, many patients who had seizures from a very early age, but didn't have the correct diagnosis initially. And in part, this is because this disease was described in 1978 by Dr. Charlotte Dravet in French. So it took a while until neurologists really pick up on this new condition. So many adults in their 40s, early 50s, they have a different diagnosis. They don't have a diagnosis of Dravet. They were diagnosed as something else. But now we look at them and we look at the physical findings that I will show you, and we order a genetic test and we can confirm that they had Dravet. And in fact, even for some of these older patients, their parents can still remember very well the very first seizure, which is a hemiclonic seizure in some of these cases. So that helped us making the diagnosis as well. So once we make the diagnosis in an adult, the very first thing we have to do is to stop contraindicated medications. And this is because some of the excellent anti-seizure medications that we have do not work well for patients with Dravet. You probably know about this. These are the sodium channel inhibitor drugs like carbamazepine, phenytoin, lamotrigine. And if you make the diagnosis in an adult, chances are this adult is taking one of those drugs. Then we have to try and keep the patient in the least amount of the medications that are used as a first and second line. The fenfluramine and CBD have been approved for adults, and can be used earlier. But at least for us in Canada, reimbursement might be a bit of an issue. But hopefully in the near future, we will have, it's going to be easier to start those medications early on. Another thing that I think it's important when we stop the sodium channel inhibitor in a patient that just received the diagnosis of Dravet syndrome is that we may see improvements in the seizure frequency, severity, and even length of seizures. The other thing is that we might see improvement in attention and coordination. And I leave this picture here just to remind me to tell you the story of a patient of mine whose mother called me one day and said, he's now swimming. And they go like, well, that's good, but I thought he was swimming before. And she told me, no, when he went to his swimming lessons, he would just splash water around. Now he's actually doing laps, he's actually swimming. And that happened after we stopped the sodium channel inhibitor drug. So we can see significant changes, patients that started communicating better after they stopped those medications. There are a small number of patients that I like to say they don't read the books and they don't do what we expect. And in fact, what happens is that in this small group of patients, when you try to reduce the lamotrigine or sometimes even the phenytoin, they have more seizures and it can be tricky. So not everybody behaves the same, but in general, the large majority of patients will do much better when they stop the sodium channel inhibitor. Now, starting Stiripentol in adults that are newly diagnosed might be tricky as well. Here is a chart where we have these green triangles in the bottom saying this is the age of when the seizures first appear. So all of them with seizures before the first year of age. The red X is when we made the diagnosis of Dravet syndrome. And you see that all of them had a diagnosis after the age of 18, some of them at the age of almost 40 years old. And the blue diamond is the age when we started Stiripentol. And you can see that, for instance, patients 2, 3, or even 13, as soon as we made the diagnosis, we were able to start the medication. Now, there were a few other patients that we had to wait longer to start Stiripentol, in part because we were reducing the other medications that should not be present, in part because the parents were a bit afraid of changing. So sometimes they would say, this is the best seizure control we ever had. I don't want to rock the boat. And I had to say, well, it could be even better than that. And there was some resistance. And for instance, patient number 7, you see the family didn't want to start Stiripentol for over 7 years. It took us a long time to be able to start this medication. Then when you start, you have to deal with the side effects, of course. And several patients had problems, which we know Stiripentol has some side effects. So problems with balance, unsteadiness, drowsiness, appetite, fatigue, mood, drooling. But one of the things that caught my attention is that some patients actually had more seizures when they should have had less seizures. And sleep problems as well. And we started to wonder, why would that happen? And we did some metabolic tests, and we saw that ammonia was elevated. Ammonia is something that is like a product that is done in the liver, and it's part of cleaning the blood. You have this ammonia that you have to get rid of, and it usually goes out in the urine. But for some reason, patients that take valproic acid could have a higher ammonia, and that ammonia, if it's toxic, it's at a level that is toxic, can cause the same kind of symptoms that you see with side effects of anti-seizure medication. So high ammonia can cause gait problems, drowsiness, decreased appetite, fatigue, mood problems, sleep problems, and could increase seizures. So that's different from the anti-seizure medication, could increase instead of decreasing. So we checked all of our patients on Stiripentol, and we saw that many of them had high levels of ammonia. So what we did, we started treating them with carnitine, which makes the cells work better and help us get rid of this ammonia. And it actually helped several of our patients, and we were able to keep them on Stiripentol. So some patients that had that were about to give up trying Stiripentol because of the side effects, we were able to keep them on the medication with good seizure control after we started carnitine. And carnitine is kind of a vitamin, so it's like a supplement. So it doesn't really cause any harm if it's taken in the appropriate doses, of course. So I think that is an important lesson that, like for so many of our patients, we had difficulty getting them on this medication that we know helps with seizures. But if you check the ammonia, and if it's high, you can treat them with carnitine, and they can tolerate the medication much better and derive all the benefits. Interestingly, despite giving the carnitine, despite reducing the levels of valproic acid and clobazam, which we have to reduce, the overall dose of Stiripentol in adults was around 15 milligrams per kilogram, and in children is 50. So we can see that there is still, for some reason, the adult metabolism is somewhat different, and on a per weight basis, adults tolerate a smaller dose of Stiripentol. Moving forward, how well do adults with Dravet syndrome function in life? It's a very broad question. So we use a few instruments to try and understand that. And one of them is the Vinelands Adaptive Behavior Scale, which is a scale that will look at several different domains in patients that have intellectual disability. So it looks at communication, daily living skills, socialization, motor skills, and maladaptive behavior. And we tested a group of patients 5 years ago, and we were able to retest them recently. But those were 9 patients only. So what we saw in these 5 years, in these 9 patients, is that the motor scores did not improve or got worse. But the good side is that the problem behavior got better. So that was like an interesting finding and a positive, hopeful finding. So we decided to understand what happens in more patients with Dravet, and I know many of you have already participated in this research. We put this research through the DSF, and I thank you all who participated. And if you still want to participate, we are going to be closing the study on July 4th, 2 Sundays from now. So you still have a chance to participate if you want, and it would be wonderful. So this study is on the Dravet syndrome website. If you go to medical care and participate in research, and then you go to the last one listed there, natural history study of adults with Dravet syndrome. So we have already received from you the results of the Vinelands in 44 patients. And this is what we're going to show to you now. Like I said, we are aiming for more patients. We would like to have at least 100 patients. As of today, which is June 4th, that we are recording this, we have 44 patients, and this is what we've seen. In terms of socialization, they tend to get worse with age. So in terms of interpersonal relations, in terms of play and leisure and coping skills, the older the patient, the worse they do. In terms of motor skills, we also saw a decline in motor skills with age. So the older patients did worse than the younger patients. And in a way, this is not so news. I mean, we did in 2014, we showed that adults with Dravet syndrome develop Parkinsonian symptoms in their early 20s. And that is characterized by what we call bradykinesia, which is slow movements and rigidity and postural instability, meaning balance problems. The antecholis, which is this neck going forward, and camptocormia, which is an excess when not only the neck, but the entire upper body goes forward. So we saw that, and we actually treated a few patients with levodopa, which is a medication for Parkinson's disease, and we have treated more over the years. And we can see that it helps, or at least it helps for a while. But we want to know if the disease is progressing. So we are looking at our own patients who we saw 5 years ago, 6 years ago, and we are looking at them again. And unfortunately, this patient in the bottom here, she's no longer walking. So she's one that had a good result with, she wasn't really walking very much. She had a lot of difficulty. And then with the levodopa, she started walking again. And that lasted for almost 5 years. And now she's no longer walking. But we want to do more of a formal assessment of our patient's gait. And you probably heard about this also in children with Dravet. So, you know, gait is a problem that starts early in life. And I will show you some of our results. So this is a patient, a female with 30 years of age. And she's doing relatively well. It takes a little while for her to start walking. But you can see she still she has a crouch gait. She has Her knees are bent. Her hip is a little bent. She walks slowly. She turns around slowly for her age. But she's doing relatively well. Now this patient, let me see if I can bring this. He's a 40-year-old male, and it took us a while to get him walking. But you see, he has a significant crouch gait. He walks slowly. Most of the time, he needs both feet on the ground. Is different from someone that walks normally, that we keep both feet on the ground for a much shorter period of time, and he needs way more time. Even when he walks fast, which he can do, he still has his feet almost glued to the floor, which is also a sign of Parkinsonism. And then we have this female who is 42 years old, who has significant balance problems in addition to the motor disorder. She has significant balance. So without her father there, she wouldn't be able to walk.
Ready? Turn around. We'll walk back. Okay. Ready? Go ahead. Let's walk.
Then we have this lady, for instance, she's 50 years old, and she has the classic Parkinsonian gait, very small steps, feet glued to the floor, the posture is stooped, her neck is going forward, the speed is slow. So that's the classic Parkinsonian gait. And this is a patient who had her diagnosis only at the age of 46. So unfortunately, she was on the contraindicated medications for a very long period of time. See how many steps she needs to just turn around. Several steps, that's what we say unblock turning. And this is a patient with what we call camptocormia, which is something you would see in patients with advanced Parkinson's disease. They have this abnormal posture. Unfortunately, this patient is no longer walking. So this is an old video that I have from her. So far, what we have seen in 17 patients is that they have several abnormalities. I listed here just a few. And you can see that here is the age of the patients. So the younger the patient, the better the score. The older the patient, the worse the score. And even the younger patient who is less than 20 years old is worse than a 62-year-old control. So this red dot is a 62-year-old control. Same thing here. Younger patients doing better than old patients, but even the younger doing worse than a 62-year-old normal control. Same thing here. But except here, if it goes up, it means it's getting worse. So the younger ones are worse than the 62-year-old, and the older they get, the worse their gait. So if you, this is with the results we did just here in our lab, but I know many of you have already sent your videos. And I am very thankful to that. And I would encourage those who have not yet done a video, please do it and send it to us. It would be important to get information from more than just 17 patients. But as you know, it's very difficult to find adult patients that could come here to do this research. So we developed this tutorial video explaining exactly what we need for you to film. You can film with your own phone, and we can help you to upload in our secure hospital database, so network. So all the information would be very secure. Okay, so to conclude, the seizures in adults tend to improve in both frequency and severity. Remember to consider carnitine if you're starting Stiripentol in an adult to help with tolerability. The maladaptive behavior, the problem behavior tends to get better, so less temper tantrums, less aggression, but the motor skills and the gait tend to get worse. As I said, I would love to have more patients so we can look at and maybe we just have a biased sample here, and if we look at more patients, we'll see something different. So we're still doing more studies to get a better understanding of our patients, the adult patients in general. And here are acknowledgements. Aruna is the graduate student who is doing this research, who is talking to families and collecting all the information and analyzing the information. We're thankful to the Dravet Syndrome Foundation who financed part of this study, and the Dravet Canada who financed the previous study 5 years ago that we had a follow-up more recently. So I'm gonna stop here and then I'll be available live for questions. Okay, thank you.
Hi, thank you so much to Dr. Andrade for providing that talk for us today. She's here live now to answer the questions that have been coming in through the chat. So we're just going to dive right in. The first question I have is regarding fenfluramine, which we know is not yet approved in Canada. And so they're just asking, if you have any guidance on, or if you know families that have been successful in being able to access fenfluramine if they're not part of a clinical trial. I can throw out that I know Zogenix just started a global access program. There's no financial assistance with that, but what has your experience been, Dr. Andrade?
I think I recently heard of a pediatric neurologist that she was successful to get fenfluramine for her patients. We are starting a trial of fenfluramine in adults. So if you are in Ontario, just contact my office. We can give you the email address later. And if you want to be part of this trial, then we can definitely include your child, if it is older than 18, in this trial here.
Okay. And I can post in the chat the link to find out more about the Zogenix Access program after this.
Yeah.
The next question was in relation to Stiripentol. And so what do you feel as a provider is the benefit to starting Stiripentol in an adult patient who hasn't tried it yet? Why that specific drug? And would you hope to wean existing meds, not specifically just contraindicated ones, but meds they're already on if they started Stiripentol? And then this same went on to just comment that one of their concerns is that a lot of the side effects you listed with Stiripentol are actually things they're already finding, already side effects they essentially experience with their child. And so, should they be more concerned with starting this medication?
Yeah, so just I want to clarify that many of those side effects that I mentioned, they showed up when we started Stiripentol, but they were probably not because of the Stiripentol, but because of the elevated ammonia, which somehow the interaction between the Stiripentol and valproic acid make this ammonia go up. And when we treated those patients with carnitine, they did well. The symptoms went away and they still had the benefit of the Stiripentol. Stiripentol is a very good drug. I have been using it for several years and in the adult population. And even though we see that the seizures have decreased already just because they are getting older, they have less seizures, they still have those lingering seizures. And several of our patients became seizure-free after we started Stiripentol. So it is, I think, if your adult child is still having seizures, I think it's worth considering doing something else to get those seizures under control. Of course, we always have to think about the balance between side effects and seizures, but perhaps with careful management of the other medications, ruling out the excess ammonia, or if there is excess ammonia, we can treat that. We can get a better seizure control without additional side effects.
Do you anticipate that most patients with Dravet syndrome will eventually stop having the ability to walk? And do you think that seizure frequency impacts the severity of gait issues?
That's a very important question. It's hard to predict. If the majority of the patients that we are looking at, they didn't have a proper diagnosis until later in life. So there's a chance that they were exposed to contraindicated medication for a long period of time. This is certainly what we see in the majority of our patients, but we are doing this larger research, and we are also asking if your adult child was exposed to contraindicated medications, because maybe that can aggravate the gait problem. And the ones I have been seeing, the older ones after the age of 45 or 50, it becomes really difficult for them to walk. They are now in a wheelchair. But again, I cannot say if they had enough physiotherapy, if they were exposed to the wrong medications, if there is any correlation between their particular genetic abnormality and their gait. So there's a lot of things that we still need to figure out. And that's why part of this research that we are doing will ask you to record a video so we can do the gait analysis and try to correlate that with genetic abnormality, use of contraindicated medications and other things, and the amount of seizures, of course, or the amount of status epilepticus. We don't know. The answer is, as of today, we don't know. We hope we are going to be able to find some correlations in the future. Yeah.
I have a quick question. Trying to find it again. Regarding your gait study, if there is a patient who's of the right age to join the study, but they don't have any gait issues, you still want them to join the study?
Yes, absolutely. Absolutely. It's very important to see the ones that don't have any gait issues, because otherwise we'll just be looking at the ones that are not doing well, and we have a wrong impression that the large majority of them won't do well. So absolutely, we want to see patients that have a normal gait. As long as they are 18 years or older, we would love to see them.
What's your opinion on things that parents of young children can do now to help improve the outcomes related to these gait issues? Like, do you think that PT and weight bearing are very important, or do you think this is just part of the course of the disease? And, what are your thoughts on that?
That's a good question too. I don't think we have a scientific answer as of today. But we know that exercise is good for several reasons. So I would think that if you can have your child do weight bearing and physiotherapy exercises, it only is going to bring good results. Even if it's not for the gait in the future, it's going to improve just the way the cells work in general. We know exercise is good for the brain. So I suspect it would improve gait, but we cannot say that scientifically. But exercise is something that everybody should be doing on a routine basis as possible given their limitations.
Okay. Do you have time for one last question? All right. So, and I think this was an important one to ask because we had some questions in the last talk that were related to this, but do we understand what the mechanisms are that underlie the development of Parkinsonian symptoms? And this is not Parkinson's disease, correct? This is just presentations that look similar. And do we know if it's a similar mechanism or if this is something different?
That's a very good question. We don't know yet. We know that SCN1A is expressed in a part of the brain that we call the basal ganglia, which is a part of the brain that is abnormal in patients with Parkinson's. So it's not a far stretch to think that the basal ganglia of patients with Dravet don't work very well as it should be working. So we would need more research to figure that out. We had a plan of doing PET studies, PET. However, it's quite difficult to have a patient with Dravet sitting or lying still for several minutes, almost an hour or two, depending on the kind of PET study we do. So it's very tricky right now to actually say if their basal ganglia is deficient or not. But given the fact that we know SCN1A is expressed in that part of the brain, that might be the relationship.
Okay. Well, thank you so much, Dr. Andrade, for joining us, for giving that excellent talk. We really appreciate it. Thank you.
Thank you.